As you will recall from yesterday, the thought is that we should personalize our approach to atrial fibrillation, use a portfolio approach, use the right technology for the patient, and not try to fit the patient to the technology that one happens to have. And that is the strategy behind Boston Scientific's thinking. And I'm very pleased to welcome my dear friend and colleague, Dheeraj Gupta, who is going to put flesh on the bones of that idea and talk about the portfolio approach. Dheeraj, the floor is yours. Thank you.
Many thanks, John, for the kind introduction. And many thanks to the organizers for giving me the opportunity to contribute to this session. So what I'm going to do is, over the next 5 or 10 minutes, talk to you about where I think AF ablation is heading over the next 5 or 10 years. But before I do that, I've got to start with where AF ablation is today in 2019. We had a very good debate yesterday about the merits of single-shot technologies versus point-by-point RF technologies for PVI. And during the debate, there was a question from the audience. How many of you do cryoballoon PVI? And I think pretty much every physician in the room raised their hand. And then there was a follow-on question, how many of you do point-by-point RF? And again, everybody, almost everybody, raised their hand. So I think that all of you already go through this thinking process on a daily basis. So you identify the right patients, and you identify the right strategy for that patient. So all I'm going to do over the next few minutes is, as you said, put flesh to the bone. So all of you go through this process on a regular basis anyway. Now, I don't need to tell anybody in this room that AF ablation is here to stay. Lots of guidelines have endorsed it strongly. Those guidelines have been underpinned by decades of research and publications. We know that AF ablation works. But one particular statement in the 2017 HRS consensus statement really caught my eye. I'm going to read it verbatim. So the decision whether to perform a catheter-based intervention in a symptomatic patient still takes into account the stage of atrial disease, the presence and severity of any underlying cardiovascular disease, potential treatment alternatives, and in particular, patient preference and operator experience. So all of this has to come together before you decide what is the right strategy for the patient sitting in front of you in the clinic. And the underlying basis for this personalized strategy approach is this one assertion that all of us can identify with. It's biologically implausible that the range of atrial pathophysiologies and their electrophysiological consequences can all be managed by a single tool set with a single ablation approach. How can a 40-year-old marathon runner with paroxysmal atrial fibrillation be the same as an 80-year-old patient with persistent AF occurring on a background of hypertension, diabetes, heart failure? And yet, somewhat surprisingly and wondrously, pulmonary vein isolation remains the cornerstone of the AF ablation approach for both of these patients at the two ends of the AF ablation spectrum. It's been 20 years since the central role of pulmonary vein isolation was identified, and here we are still doing pulmonary vein isolation, trying to get as good as we can with this. It doesn't really matter whether you use cryoballoon or whether you use point-by-point RF. The fact of the matter is that most randomized studies have shown that the two are fairly equivalent. In the seminal Fire and Ice trial, we saw that there was a 2 in 3 chance that a single procedure would render a patient with paroxysmal atrial fibrillation AF-free at a year. In the more recently published Circa-Dose trial, when head-to-head sort of modern technologies were compared, which included second-generation cryoballoon and contact force sensing catheters with force-time integral targets, once again, the two were similar. The overall results were better. Rather than 2 in 3, now you had 4 in 5 patients benefiting from a single procedure at a year, but there was no difference between the two of them. So, AF ablation in 2019. Durable and safe pulmonary vein isolation is now a reality in many labs. Not all labs, as we will see, but in many labs. But what that also means is that non-pulmonary vein dependent atrial fibrillation is increasing, especially in persistent atrial fibrillation. That's something that Richard alluded to in the debate yesterday. It's a headache. It's a good headache to have, that you now have a patient who comes to you after a successful pulmonary vein isolation with a recurrent AF. Earlier, it used to be easy. I used to schedule them for a repeat procedure because I knew I was going to find PV reconnection, low-hanging fruit. You isolate the veins, the patient feels better. But now, it gives me a headache. Because I know that when I take the patient back to the lab, the veins are likely to be isolated. What do you do then? How do you personalize the management for that patient? So I often tell patients that rhythm control is a journey. If you're lucky, that journey will finish with one procedure. But if you are the typical patient that I see, that I have been managing, you're likely to probably need more than one procedure. You're likely to need holistic management. You're likely to need management of risk factors, hypertension, obesity, sleep apnea. It's going to be a journey that you and I are going to go on together. It's also fair to say that 20 years after the pulmonary vein triggers were identified as being central in the pathogenesis of AF, we still don't quite understand the mechanisms beyond pulmonary vein isolation. So the AF ablation procedure or AF ablation prescription still depends more upon the operator than upon the patient. It's what I'm comfortable with. And there's nothing wrong with it. At the end of the day, what you can deliver safely is important. But in too many laboratories, too many operators just do what they think they can do best, not necessarily doing what the patient might actually need. So there are lots of reasons why single-shot technologies have become popular over the years. Short procedure times leading to high throughput, same-day discharge. In our hospital, same-day discharge following cryoballoon PVI is now the norm. Certainly all the cases done in the morning, they go home the same day. Ease of setup. So you don't need 3D mapping. You need less physiologist support in the lab. Short learning curve, and that's absolutely important, that it democratizes the AF ablation. It levels the playing field. You know, people can get reasonably good results without having to do hundreds and hundreds and hundreds of point-by-point RF operators. So more widespread uptake is possible. Non-academic centers, non-surgical centers can start doing AF ablation. And as we heard yesterday, there is a demand for AF ablation out there. So we need to do this. And yet 3D mapping and RF ablation still has a role. It offers you versatility. It doesn't matter what the pulmonary vein anatomy is like, whether you have a common vein on the left side, whether you have an additional vein on the right side, whether you have a roof vein, it doesn't matter. RF point-to-point will get around it. It doesn't matter how large the left atria are. If you want to create really wide circles, you can do it. You're not going to be limited by the anatomy as you will be with a balloon. If you want to target extra pulmonary vein triggers, and sometimes you will need to, the patient might have documented flutter, then you can do it. If you want to isolate the posterior wall, if you isolate the left atrial appendage, which again we're going to hear more about later on today, we can do all of that. It also gives you a diagnostic capability. You know, with cryoballoon, you lack that. But with this, you can see for voltages, you can see for conduction blocks, you know, functional and real conduction blocks, and you can then tailor the prescription of the ablation according to what you find. So give a bespoke lesion set, something that operators in Zurich and Leipzig have been advocating for a few years. And then there is the more fundamental, more philosophical question about maintaining the skill set of current and future EP trainees. You know, if point-by-point RF ablation dies a death, then what really separates us from, and there's nothing wrong with it, but what really separates us from the interventionalists in terms of all you're going to do is just blow balloons in the vein. So we need to be able to manage more complex arrhythmias and be able to navigate our way in the left atrium. And perhaps we need to maintain those skills. And this is particularly important because some very sobering data were published last month in the Journal of American College of Cardiology about the RealLife AF ablation landscape in the US. So the investigators looked at 60,200 admissions for AF ablation in the United States between 2010 and 2015, and they're trying to look for early complications and early mortality following AF ablation. What they found was, and this is an absolute staggering statistic, that 1 in 200 patients who had AF ablation in the United States between 2010 and 2015 was dead within a month. Just let that sink in. I mean, I couldn't believe it when I read this paper. Now, the complication rates is increasing. If you look at quartile to quartile from 2010 to 2015, the complication rates have gone up. Mortality rates have gone up. It may well be that it's the comorbidities that are higher. So more and more patients who are undergoing AF ablation, at least in the United States, are complex. They've got heart failure. They're older. They've got diabetes, etc. But still, that is a sobering statistic. Now, once you took age and comorbidities out of the equation, the factors that determined early mortality following AF ablation was A, incidence of peri-procedural complications, tamponade and stroke. Perhaps no surprises there. 2, congestive heart failure. Again, no surprises there, but now following the publication of some congestive heart failure AF ablation trials, possibly this population would increase even further. And most importantly, low AF ablation hospital volume. And this is the same thing which the paper from Deshmukh in 2013 had shown, that at the end of the day, AF ablation is as safe a procedure as the experience level of the operator. And if the hospital has low volumes, you're going to have higher complications, you're going to have higher mortality. And so it's important to get this message out there. So patients present to us at different stages of their journey. And you can choose the right tool depending upon when they present to you. So for that 40-year-old marathon runner, in my example, you might say, all I'm going to do is cryoballoon PVI. And chances are you'll fix the AF. And if the patient then comes back with more AF, you can then offer them an approach in which 3D mapping will be necessary to look for PV gaps. And chances are, if you find PV gaps, you tackle them with 3D mapping and RF, you're going to then fix the patient. On the other hand, for that 8-year-old patient with symptomatic AF occurring on a background of multiple comorbidities, you might think, cryoballoon might work, but perhaps do I need to give him a more individualized lesion set? Do I need to isolate his posterior wall? Do I need to look for triggers? You might then decide to give him a slightly more sophisticated, for lack of a better word, a procedure in which you might want to map the substrate and then tailor the ablation set accordingly. So there are 3 key considerations for a successful AF ablation program. Number 1, and that's always number 1, patients. Number 2, physicians who look after the patients. Number 3, administrators who look after the physicians. Oh, well, they're supposed to look after the physicians, but actually, what the administrators are really interested in is efficiencies, throughput, how they can put most bums on the seats, how they can get the lab throughput quickly, how they can minimize the hospital time. So all of these stakeholders have slightly different preferences. So patients, for them, safety is foremost. So a patient won't mind coming back for a second procedure if you can guarantee them that each procedure will be 100% safe. So it's important, it's beholden upon us to make AF ablation 100% risk-free. It's possible, it's certainly worth going for. For physicians, efficacy is important, but ease of workflow is important. We've got 20, 30 years of professional life, so we've got to look at our own health. We've got to look at the ease with which patients flow through the lab, how much leg time we have, those kind of things. For administrators, I've already told you, for them, the most important thing is bums on seats. So it's no surprise that single-shot technologies have caught on, because in some ways, they actually do make everybody happy. They're reasonably safe, even with low-volume centers. Physicians like the workflow. As somebody was saying yesterday over dinner, you can actually just put the balloon in the vein, freeze, and have a chat with each other. Or you could just sit down at the back and let the fellow do the job, which is great when we had fellows. So you can do that kind of thing, which probably you can't do with point-by-point ablation. And of course, administrators love it too. And how you might choose one over the other. So this is just one paper in which these authors from Down Under have put forth their approach as to how they might choose one technology over the others. So in our hospital, there are other more mundane practical issues that sometimes determine whether we choose RF or cryo, such as availability of general anesthesia, waiting list times, what is shorter, what is not. So all of those issues will come in mind, but in the individual patient, you can look at these things. You can even look at pulmonary anatomy and see if it's suitable for single-shot technologies or point-by-point RF. So in terms of a portfolio approach to PVI, it's important for a center to have as many strings to the bow as possible. So you should have the cryoballoon or single-shot technology. You should also have the ability to offer them a more, as I said, sophisticated point-by-point procedure if necessary. So because isolating the pulmonary veins is just one step in the journey for AF ablation freedom for many patients. What do you do after pulmonary vein isolation? That's literally like opening the Pandora's box. No one knows. A lot of things have come and gone, whether it was linear lesions, whether it was cafes, rotors. I don't think any of them have really stood the test of time. The current fashion is left atrial appendage isolation followed by occlusion. That might well be the answer we're looking for, but I think the jury's still out on that. So it's very important that to realize that uncertainty beyond the pulmonary veins has resulted in a plethora of approaches. So if you go to 10 different EP centers, you'll probably see 20 different approaches for patients with persistent AF. Some would always isolate the posterior wall. Some would always isolate the left atrial appendage. Some would do a more Leipzig oblique Zurich type approach of identifying low voltage areas and targeting them. The fact of the matter is, a lot more research is needed. And we need to have the tools to do that research. So, Boston Scientific, one of the things that attracted me to Boston Scientific was the fact that they do offer a wide portfolio of products. So unlike just concentrating on single-shot cryo technologies like some companies do, or just focal RF, they have tried to have something for everybody. So they've got Rhythmia, obviously, which is state-of-the-art mapping system most of us are familiar with. And they're working hard on their RF ablation catheters to make them competitive. But they're also now investing in the single-shot space, both in terms of cryo and in terms of RF balloons. And hopefully, we'll see a few more early results later on in the day. So, to conclude, a high-volume, factory-line, standardized PVI approach has merits and has some role in improving efficiencies. However, there is a growing need for an individualized approach, for a bespoke approach to the patient. And so one size may not fit all. And it's very important that we as EPs realize that we need to be able to offer a wide range of therapeutic options. We don't want to be left as just one-trick ponies. Thank you very much.
Well done, Derek. Thank you very much.